with us this morning and you know, talk to us about some of the specific issues that we're facing as surgeons and as the rest of the operating room team. I see we've got a pretty good people that have already logged on, over about 130. I'm usually happy at surgical ground rounds to have about 5 people in the room. So 130 is pretty motivated crowd to listen to have you teach us and update us. I'm happy to monitor sort of the chat at the end and help with moderating questions. I'm sure there will be some, but I don't want to eat into more of your time. So please.
Okay, thank you, Leanne. I did a sound check and people before said it sounds good. And I see in the chat that somebody has already found that I have the wrong date on the title slide. I'm sorry about that. I'll change it before sending you a PDF. And at the end, I can then have a PDF that's posted on your departmental website. So I'm Marcel A, and I'm at the helm of a virtual boat here. And Frenette is behind me. We both have little hand washers so that we can take turns. I start with this image of Leonardo da Vinci that's reimagined on Zoom. As you can see, the apostles are all zooming in from different computers. You see all the apps at the bottom. And if you look in detail, you'll even see that the artist has added a little Purell container before he eats his dinner. And I think this image tells me 2 things. It tells me that this crisis has brought out the best in everybody. We see artists who are coming up with incredible new reimaginations of Da Vinci. We're seeing Samuel Jackson reading fantastic bedtime stories. I have scientists approaching and asking, how can we help out? Physicians and surgeons who are stepping up. So I think this image really reminds me of the incredible collaborative spirit of the crisis. The image also reminds us that physical distancing is not the same as social distancing. As Leanne knows, I've been on faculty for 20 or so years, and I've never been invited to either attend or speak at surgical grand rounds, which just shows that we're actually building new social bridges even while we're maintaining 2 meters distance. And I hope we can use this opportunity to forge new relationships and find new ways to work and better ways to work altogether. Briefly, this is probably an accredited event, so I put in the standard disclosure slide. In terms of COVID research, I have nothing to declare. I work on tuberculosis funded by government agencies. In terms of the current status of COVID research at McGill, the level 3, biosafety level 3 tuberculosis lab at the Research Institute has been accredited by the Public Health Agency of Canada for COVID research as of last week. So I am a newly recognized COVID lab director, but I am not a COVID researcher. As I told the virologists, I'm going to be the paving truck so that they can bring in their Ferraris. Frenette is the head of infection control, and I have put down no conflict of interest unless he wishes to change his opinion on that. And thank you to Richard for pointing out the Last Supper is a Seder. Great comments. I'm going to try to not read the comments, but I think they're actually more interesting than just talking forward. I'm going to talk about some epidemiology, a high-level view of microbiology, and some personal reflections on the collective goal of what we're all trying to achieve. Charles is a really practical guy, so if anybody wants to know what to really do, you can check your emails for the next 15 minutes and then wait for Charles to come in, where he's going to give 4 case studies, and each has a lesson learned. And I hope that we can get this done so there's plenty of time for questions and for comments. So very briefly, you want to know why you're listening to me, and I can tell you why you shouldn't listen to me, because I'm not a virologist. And in fact, I'm learning something new about COVID either every day or every hour. Despite that, I think there's a couple of reasons why I think I have some useful perspectives here. In my clinical world, I see TB patients. In my research world, I study TB. I've been thinking a lot about aerosols and droplets and transmission in my genomic epidemiology research. I've run a biosafety lab, level 3 research lab for over 15 years. in which time nobody has converted their tuberculin skin test. So I have some understanding of the risk of spreading respiratory pathogens. And I would say that at the bottom right, I think it's also a plus that I'm learning something new about COVID every hour. Briefly, the epidemiology from yesterday. This is about at noon. So if anybody there has gone on to a WHO website this morning at 7 a.m., I'm sure the numbers have changed a little bit. Globally, the world has about 1.4 million cases. Canada is 18.4 thousand. Canada's population is about 1/200th of the world's population. So does that mean we are enriched or we have better testing? And I suspect it's better testing. If you look in Canada, Quebec is about half of Canada cases, and we are just under a quarter of the Canadian population. Once again, you could say, is Quebec a hotspot for COVID, or is Quebec a hotspot for testing? People who are listening in may think it's hard to get a test, but if you look at the statistics, Quebec actually has almost double the testing of Ontario. So you should just appreciate that the numbers we see are to some degree biased by the availability of testing. If you go from the top to the bottom on the left, you'll see worldwide there's 82,000 deaths. Canada has 402, and Quebec actually only has about 1/3 of the deaths or maybe 40% of the deaths of Canada. So for instance, Quebec has twice as many cases as Ontario, but the exact same number of deaths. And a lot of epidemiologists think that reflects an underreporting in Ontario compared to Quebec. On the right side of the screen, you see from the Quebec Santé Canada that there is this curve that everybody's looking at. And I can't tell you how many times somebody's told me, I follow the curve on La Presse, I follow the curve on CBC, I follow the curve at whatever any website possible. And I think the hard part for most of us is to try to figure out, is it going up in an additive manner, or is it going up in an exponential manner, or is this a polynomial, or is this something that we learned in high school math that we've forgotten since then? Yes, as of yesterday, Quebec had just over 10,000 cases, and at the bottom they have the number of new cases per day, and the new cases per day is more or less similar for the past 5 days. So it suggests it's additive, but I think all of us are still trying to figure out whether the curve is really flattening or not. The one thing I've become convinced of by looking at these curves on Twitter is this image, which is that for all of us, the amount of time we've spent looking at exponential graphs has gone up exponentially since January. And so some people who I follow on social media have converted these exponential graphs into much more digestible manners. This is from the Financial Times, and this is a graph of deaths. And what this John Byrne Murdoch does is he doesn't put it as January to March, he doesn't put it as day 1 to day 60 or whatever. He starts every single country here at the day that there were 3 deaths. And the idea is that different countries had the epidemic starting at different days, so that once you justify everything at the same point, you see that generally speaking, there's 2 major clusters. There's the group of countries that go up at this rate, and then there's South Korea down here. And this curve of deaths is probably most useful for those of you on the line who are working the ICU. The deaths are going to follow 2, 3, 4 weeks after the transmissions. So this gives you an idea of the burden on the healthcare system, the amount of very, very sick people. And what is somewhat encouraging is if you follow US, UK, Spain, and France, you'll see that Canada seems to be maybe falling a little bit off of the pack, and maybe we're flattening. And this is something that I think we all are very optimistic for. We want to be able to take care of our patients, and we want to make sure there's more ICU beds than patients. And hopefully that's where we're going to head, but there's obviously different projections for Quebec. If, on the other hand, you want to know how many cases there are, this is slightly more at the front end of the epidemic, and it gives you a better indication of how much transmission there is. Here, it's a little bit more chaotic, but nonetheless, you see the US started off here and is now winning. France, Spain, and Germany and Italy have all flattened off. and Canada is down here. So on a number of cases, we are also falling back. The number of cases, as I mentioned before, doesn't necessarily mean the number of people who are being infected or how many people are transmitting infectious, because the number of cases depends on the availability of diagnostic testing. And I'm a strong believer that if we had more capacity to test, we would see more and that we would be able to act more upon it. So these are just some of the numbers today, but at least two of the indications that Canada is not quite at the level of UK, Spain, Germany, Italy, and US, but we can't really let off yet either. I'm following a number of people on social media who say, I don't know anything about COVID or epidemiology, but I have a unique skill set. And I think it's very important to listen to people who bring in complementary ideas. This is from a physicist who wrote a little YouTube video and said, in physics, we deal with big numbers and very big numbers and very, very big numbers all the time. And what we do is we plot everything in log versus log. And as a physicist, I don't think the virus cares if it's March or April. The virus is looking for more hosts. So what this person said is, I just want to know if the number of cases out there is leading to the same number of new cases, and that tells you that it's an ongoing epidemic, or if the number of prevalent cases is leading to less and less new cases. So this is plotted as new cases versus total cases, and you could do it with any data set you want. For Quebec, it looks like the following. As we go forward in time, we have more and more total cases on the x-axis, and those total cases are generating new cases, which are secondaries. And when we had 100 cases in Quebec, we were getting about 20 cases per day, new cases. So it took about 5 people with COVID to create 1 new case on per day. And nowadays we're up at around 10,000 and we're getting about 800 new cases per day. It looks like it's taking 12 people to create 1 new case per DM. So that's a sign that maybe we're getting a little bit better, because the people who are out there with COVID are generating slightly less new cases per DM, but I think we would really like to think that that's 100 that is creating a new case, and that we have to go a little bit farther. But that gives me some reason for optimism at this point. And yet it also reinforces that what we're doing, if it is working, we have to keep doing it, and we don't really know for how much longer. I previously was the head of the microbiology lab here, and I just like to give a little sort of philosophical view of how we can help. And as people have been commenting, obviously the amount of microbiologic tests informs the epidemiologic curves. Briefly, I see the microbiology lab as offering 2 services. One thing is called clinical tests, and the other is called epidemiologic tests. I see the blood culture as a clinical test. It helps you and me and all of our colleagues figure out why somebody's in septic shock so we can tailor the antibiotic therapy. I see the MRSA screen as an epidemiologic test. It doesn't change the way I manage a patient, except occasionally, if they have gram-positive cocci in the blood, I may add vancomycin until I am sure. But generally speaking, it's an epidemiologic test. I see tuberculosis as a clinical test and an epidemiologic test. It informs me of how to treat the individual patient so that I can cure them of their illness, but it also informs both our hospital and our provincial public health of a transmissible disease. So that's an example of something that is both. From my perception, the SARS-CoV-2 PCR is really mostly an epidemiologic test. Why do I not think it's much of a clinical test? Well, I'm sitting on the committee that created the MUHC guidelines for the management of COVID-19, and I can tell you that sadly the guidelines are not all that complicated. If you're an outpatient, we recommend acetaminophen, and if you're an inpatient, we recommend acetaminophen plus recruit to clinical trials. So I can't really tell you that the SARS-CoV-2 PCR is changing a lot how we manage the person on the ward with the infiltrates on their chest x-ray. I see this really as an important epidemiologic test that informs hospital infection control and Montreal public health about who is transmitting and who they are transmitting to. So when should we be doing this test and how can we use it? Basically, there's two settings where you would consider using the test, and I would put this into a categorical thing called symptomatic and a categorical thing called asymptomatic. Clearly, the world is not so binary, and let's just remember that somebody who is asymptomatic today may be pre-symptomatic for something tomorrow, or they may never become symptomatic. Lots of people are CMV seropositive, but they don't remember ever having gotten CMV disease. And also, one person's sniffles is another person's cold. So let's just be clear that this line between symptomatic and asymptomatic is a bit of a naive division. It's a useful construct to think about things, but I think we all know it's more of a spectrum than a delineation. If your PCR is positive and you're symptomatic, then of course we say you are a COVID-19 case. But if your PCR is negative and you're symptomatic, we can say, well, okay, maybe you've got a pneumococcal pneumonia, or maybe we sampled your nasal swab when you actually have a viral pneumonia and we should have sampled your ET aspirate. Or maybe the virus is gone, but it's 2 weeks later and we're seeing a whole bunch of host pathology. And so you're probably a COVID-19 case, but we are sampling you after the virus is gone. So the symptomatic is what the MSSS is guiding us to do right now. And people are going to say, well, the test is only something like 90% sensitive. And that's probably just the way it works. There's a lot of tests that are 90% sensitive. I can tell you that in Canada, about 90% of people who are declared to have tuberculosis have a positive culture. But we as physicians decide that the other 10% probably have TB, and it's better for them to treat them as if they have TB than to say the culture is negative. So that's the guidelines as we are right now. And we'll talk about GeneXpert later on in the Q&A. Thank you for that question. Really, the question that keeps me up honestly at night is I'm worrying about the asymptomatic. And I think a lot of us are worrying about the asymptomatic. And are these people who are positive and asymptomatic, are these people who are never symptomatic? And the best data would come from the contact investigations in Korea, where you have somebody with COVID-19 and you do PCR on all of their asymptomatic contacts and you find some of them are positive. And then you follow those people forward. And the question is, are there people who are completely asymptomatic, or are there people who are pre-symptomatic, who you're picking up people who have the virus today who are going to be sick tomorrow or the next day? And the yield of looking at asymptomatic people is obviously going to be dynamic. You can do it in concentric circles like Korea, and then you'll have a certain yield, or you can say we should just do it across the province and let's get all 8 million people PCR tomorrow and let's do it again next week. And obviously the yield is going to vary by who you target and where you are in the epidemic. And hopefully if you are asymptomatic and you are PCR negative, we can assign you to the simplified box called the worried well. But I think what worries me is when I'm on the COVID ward and I know somebody has COVID and is PCR positive, that doesn't actually worry me. I know exactly what I get. Where I'm worried is our blind spot, where we are not looking, and where we are not looking is where we have the potential to be spreading it around. So, questions I've received by contacting some of your colleagues. I understand we should defer non-essential surgery. I understand that we should test symptomatic patients. But how can I control risk in the operating room proper? What are the aerosol generating procedures that I perform, and how can we attenuate that risk? And does everybody have the same risk? And if so, shouldn't we screen everyone with PCR before they go to the OR? And this is obviously something that is a contentious topic, and hopefully, like a lot of things with this epidemic, the guidelines will continue to change as our understanding goes forward. So currently the issue is that the SARS-2 testing that we do in the Clin Micro Lab is finite. For a while, it was done by only one lab, the Provincial Reference Lab, and only about 3 weeks ago or so, it was decentralized to our hospital labs. And I can tell you that the numbers are growing and growing every day. So there were days that were 100 and 200 tests. And the latest I saw was 835 tests. Our capacity is getting better. And as our capacity is getting better, the government will be revisiting, hopefully, their priorities. I ask as a rhetorical question to my colleague Infection Control, who is sitting beside me, why is it we do an MRSA on all admissions and we don't do a COVID on all admissions? And hopefully this is something that we can all reflect on, because we are in a pandemic right now. And I think a lot of people would like to think, could we be part of the routine orders? In terms of what you do with the result, though, I think it's also worth reflecting on how useful the result is. So let's say you did a swab on Tuesday and the lab returned it yesterday as a negative, and you're going to the operating room on Thursday. Can you feel absolutely confident that the negative on Tuesday tells you there's no risk today? Well, of course, it depends on whether that person was in contact with a COVID-19 case 5-7 days ago. So I think a lot of us don't feel that we can absolutely rule out risk on a negative PCR. And from some of the surgeons I've talked to, their concern is really more, what can I do with a positive PCR? So how does a positive PCR help you? I think that some of the surgeons I've spoken to have said, well, there are surgeries that really need to be done and they're really important, but if the PCR is positive, I'd like to defer it by 2 weeks. And I think that makes a lot of sense. But if you cannot defer it, then I think you're really left with saying, we need to have the best PPE possible in the OR to make sure we protect the anesthetists, we protect the surgeons, and that we have confidence that everybody can do their work to the best of their ability. Because I think we all agree the goal here is to stay healthy. Do we think that all operations are equal? I don't think so. I can't say that somebody has done a systematic review and meta-analysis of risk, but from my informal conversation with you and your colleagues, I would expect the highest risk in the operating room is where you breach the respiratory mucosa, and that would be the ENT surgeons and the thoracic surgeons. I haven't actually been able to reach out to the ophthalmologists, and hopefully there's an ophthalmology listening in who can discuss what their association has proposed on this issue, and maybe Charles has further thoughts on that. The other question I've heard is a broader version of the first question. I understand we should defer non-essential surgery, and I understand that we are being instructed to only test symptomatic patients. This broader question says, from my point of view, the operating room is a controlled environment where we can control the intubation, where we can control our PPE, where we can decide when to operate and how to operate. But what about the entire patient trajectory? Are there patients in whom the risk of transmitting is high if that person came in with undetected COVID-19? And again, this leads to the same question at the end, which is, shouldn't we be screening everyone? And as somebody just pointed out, if I mentioned that this is about the surgeons only, I'm sorry if that was the message I was conveying. This also affects everybody in the OR, so thank you. It's also the nurses, the RTs, the PAVs, every team member in the OR, and the same thing for the patient trajectory. All of the healthcare workers who involved in the care of this patient could be at risk. And here the example that Michael Heyer gave me is if somebody is completely asymptomatic who comes in with head and neck surgery, and post-operatively the person has a tracheostomy, and then that person has what we think is an aspiration pneumonia and has an abnormal X-ray and has failure to thrive post-operatively. What if that person has COVID-19, and how many people in the hospital will be exposed before we make that diagnosis? And this is, of course, beyond the surgeons. This is to everybody. So here for the patient trajectory, the way I see it is, of course, the COVID testing is finite, but getting better. The government has set priorities. And as I pointed out, we were doing MRSA admission. I think in an ideal world, we would like to think it would be prudent to do COVID on mission. So where I've been reflecting on this is that when we have guidelines that are written in a dynamic era, the risk is going to be dynamic as well. If we have a guideline from March 1st, we could say, look at where all the transmission is happening and we want to stop the transmission. But as I walk around now, I sort of see my house as a closed circuit. I see the Manoir Westmount where my mother lives as a closed circuit. I see a lot of people who I Zoom with or I phone with, and they're in closed circuits. And to me, one of the only breaches of these closed circuits is our hospital. And I'm really concerned that our hospital is going to be one of the dominant sites of COVID transmission if we're not careful, because this is where Charles and I actually meet. And this is where other people actually meet. We are 2 meters away and we're doing hand washing, but nonetheless, I think we would all feel remiss if the hospital became the primary site of transmission in our community. And so I ask as a question to all the authorities, should we be prioritizing testing based on the pretest probability of being positive or based on the pretest probability of doing harm? And I think our collective goal in the hospital community is to avoid a nosocomial super spreading event. I use this term very deliberately. There is something called a super spreader, and that assigns culpability to the individual. And I don't think there's any patient who would want to be a super spreader. I think a super spreading event has to do with a patient, a room, the environment, whether they're in negative pressure, whether the windows are open, and all of the collective things that happen. And I think all of us want to know that we are not involved in any way in a super spreading event. The third question I have had before I turn it over to Charles is, I understand PCR is hard to get, and somebody says, the literature says that the CT chest is really more sensitive than PCR for screening of asymptomatic COVID. Should we do a CT on everybody, or should we do a CT plus PCR on everyone? And I've read some of the guidelines, thanks Lorenzo, and I also went to Radiology yesterday, thanks Alexander Semyonov. And what I was able to find is the CT chest can be positive in people who have COVID disease. The CT chest was positive in people where the PCR was negative, and therefore the first series said, therefore the PCR has low sensitivity compared to the CT chest. But we really don't know if those people had just a pneumococcal pneumonia or flu or something else. And most of the radiologists considered it was a flawed retrospective study. And it's hard to say the PCR is bad compared to the CT if you don't know what people had. Over here, if you have PCR positive and CT negative, typically the PCR is positive earlier and the CT becomes positive later. So the CT chest can be negative before the pathology sets in. There's very little information on the CT chest and the asymptomatic, because after all, who does CT chests on people before they're sick? And the consensus that I was able to read, and before I spoke to Jeff Jankowski, is everything I read said, this is not a good screening test early, this is a better diagnostic test and prognostic test later. And then I found out that the Department of Radiology has also concluded it is not a screening test in the asymptomatic people. One of the radiologists I spoke to said, if you really want to know whether someone has COVID-19, do a PCR. So that's my perspective on CT. I think the COVID crisis has brought out the best in everyone. And please, if you have new ideas and new perspectives, please do share them. I think the patients need all of us. And we see from the media from Italy and from China and other countries that when there are sick healthcare workers, it's really demoralizing for us as a community, and sick healthcare workers are also contagious and they can contribute to onward transmission. We also know when there's a few sick healthcare workers, there's a lot of quarantined healthcare workers, and that also erodes our workforce. And then all of the people who are not sick and not quarantined, it still has the tertiary effect of affecting the morale. And we read, for instance, hospitals like in Detroit, where the hospital and medical and nursing staff are resigning because they just don't feel it's a safe environment. So let's try to make sure we avoid all three parts of this iceberg here. So I'm going to hand it over to Charles. I just want to point out that Charles is very busy. He's getting a gazillion emails a day from everybody on every question. So if you have any questions about this talk in particular, which I volunteered to do, and then I brought him in, please send your questions to me and not to Charles. And I would like to thank the people who were not at version 1.0 at the dinner. So here's Lorenzo, Kevin, Leanne, Mike Heyer, Eva Rida, and Charles, who have all contributed ideas to this presentation. And after Charles speaks, don't forget there's a little chat button, and I look forward to hearing your questions. At this point, I'm going to switch the screen here, and we're going to try to get on Charles' presentation and see if that works. And now Charles will take over the driver's seat, the captain's seat.
Thank you very much. I'm going to clean the mouse. Make sure. So I know you probably have a million questions you've had for me. I will not go into the superb protocol that Leanne has revised many, many times and has consulted us. But I really want to share, practically speaking, what we've been seeing in the last 6 weeks. I told my spouse this morning that I felt I was going in a shooting alley and that I would have, I don't know how many eyes in me all wanting to shoot at me. So please don't shoot the messenger. I was lucky enough to see K0 at the NUHC, and I want to share this with you. This was a 19-year-old girl, known sickle cell, was followed at the children at Saint-Justine, but just been transferred here, and she only had a chronic wound on her foot. She traveled to France during spring school break from February 27 to March 8. She developed fever in France and increasing wound pain March 6. She went to emerge there, stayed 24 hours. She was treated as if she had a sickle cell crisis. But she took the plane on her way back. She came right off the plane to the Glen emergency room. And thankfully, because we had a good screening process in place and we knew that France was a high-risk area, she screened positive in the triage with the travel and fever history. And she was put in, at that time, airborne precaution and tested. She was very, very disappointed. The mother was upset that we thought she had COVID and that she signed herself off, very dissatisfied with care. And she said, I'm going to go to my old hospital, which was Saint-Justine, and they give much better care than you do. They treat us like humans, not like pest people. So she goes to Saint-Justine March 9th. And Saint-Justine again did their job because they screened her, travel, fever, and they didn't know that we had tested her, but so they tested her again. We get a result from the next day, the March 8th, that the result is negative, but the patient's not here, so we don't really care. But on March 10th, finally, the patient's transferred back to our emergency because she's an adult and she's followed by us for sickle cell. And about a couple hours after she's back, I get a call from the LSBQ to tell me that the test from Saint-Justine, the one on March 9th, was positive. I look up and says, well, listen, it was negative March 8th at our place. So do you know what you're doing? And so, so the short story said, well, retest her. So I go back, see the patient, and again, believe it or not, she never wanted to be retested. So here I went back to LSBQ and asked them, well, can you do the retest? And they redid the test and they said, well, listen, the Saint-Justine test is a real positive and yours is really a negative, and that's the way things are. So lesson 1, tests may be false negative. Why could they be false negative? Probably the most likely thing is inadequate sample. For those who have done that test, some people just jerk at it. You're supposed to do 5 rotation in the nasopharynx. The only way I know I've done a good test is I've induced a tear from the nasopharyngeal ocular reflex. If you're very, very early on in disease, maybe your viral load is not that high. Or if you're late in disease, where the disease is in the lower respiratory tract, and you've sampled the upper respiratory tract. what we see in studies is a sensitivity of 80 to 90% in symptomatic. So all these are reasons why we may have false negatives. Now, I'm not a molecular biologist, but contrary to MRSA, which is very stable, RNA viruses are very unstable. There's no permanent state of RNA viruses like DNA virus in our body. And MRSA, the median carriage time is 3 years. So that a negative test yesterday or positive yesterday is quite predictive of what you're going to have tomorrow. That's not true for RNA viruses. Our test is done with a primer that's about 20 nucleic acid, and the whole virus is about 30 kilobase. And once we detect RNA, we have no idea whether it's live or dead virus. In fact, some studies on convalescent people, we have PCR at day 10, day 14, day 21. With deep sequencing, they've shown that whatever we detect are just RNA fragment, that there's no full viral sequence. So we don't know when we have a PCR whether it's live virus. And as Marcel has told you, negative today does not mean negative tomorrow, as our case has illustrated. Case number 2, getting closer. A 58-year-old male who was transferred last week from Verdun with a diagnosis of empyema refractory to lysis, and he was transferred for decortication post quote-unquote community-acquired pneumonia on March 30th. He was febrile at Verdun on admission for 1 week. He had a test at Verdun before transfer, and that test was COVID negative. He was operated on the 31st. It was supposed to be done under laparoscopy. It was complicated. It was converted to open. He ended up with a chest tube. He had cough, some mild fever post-op, and then we tested again, and his test was positive for COVID-19. So another case of pre-op COVID negative, and he probably had COVID all along. Lesson 2 learned. Well, this patient was symptomatic on admission. Since the beginning, since January, we say anyone with a cough, you put in contact droplet precaution. Now, the OR staff was okay because they took all the precautions, but MGH11 had now 14 healthcare workers in quarantine because of that exposure. The second thing is Verdun declared an outbreak March 31st. They had 52 nosocomial cases. 3 of their patients were transferred recently for COVID in our ICU. I don't know how many. I know they had many healthcare workers infected. So this case is probably their case number 53. They probably don't even know about it. So the message number 2 is COVID will get to us through unrecognized symptomatic patients. And that's why the list of 10 symptoms that I have here should be asked to every single patient on admission. They're asked in emergency about these 10 questions. Elective transfer should have the same screening process, either done by the nurse, the doctors. I would say when you accept a transfer, make sure you have the answer to those 10 questions. Case number 3. This was an 80-year-old man who was admitted with a pericardial effusion for a pericardial window secondary to a metastatic mesothelioma. He was, I guess, admitted semi-electively March 31st. He had just returned from Detroit 8 days before. From Detroit. You just heard about Detroit. No one noted that in the charts. No one asked that in the patients. He had cough, was presumed to be because of the mesothelioma. There's no note of shortness of breath. There's no note of fever. And he was operated April 1st. Post-op, the wife calls us and says that she has a respiratory tract infection and that she's been tested and that she's COVID positive. And because of that, we tested the patient, and on April 3rd, the patient was COVID positive. And a CT of the chest indeed shows some new infiltrate compatible with COVID. Lesson 3, we have to do better history on admission. There were 3 things here that merited contact droplet precaution. Travel to a very high risk surgery. What should have been done? Could we have deferred surgery for 2 weeks? 2, cough, contact droplet, test. And finally, have you had contact with someone who's confirmed? You get that question asked every morning when you walk in. You have to ask it to your patients as well. Case number 4, and that brings a little bit to what Marcel was alluding. How is COVID going to get in our system? This is a case, March 16th, a resident develops diarrhea while rounding with some chills, maybe fever. She goes home that same evening, March 17th, and she really feels crappy, so she doesn't come and work on March 18th. 2 days later, March 19th, she still has a little bit of diarrhea, but she feels better and her staff is all alone, so she comes and works. March 19th, while she's working in the afternoon, she learns that her mother is also sick, this time with a respiratory tract infection, and that she has tested positive. What was the story of the mother? Well, the mother had been in a party the weekend before with people returning from Florida, and one of that person was confirmed COVID positive at the Jewish. And obviously this resident had seen her mother a couple days in between. Now, her attending with whom she was working with developed a respiratory tract infection, but did his regular work round that day, got tested the next day, and he was COVID positive. One of his colleagues became positive. Secretaries, technician, and housekeeper were positive. We had 4 PABs in the OR who became positive, transport personnel, and in total, we had 13 healthcare workers that were confirmed. No patients. And I'm only happy that 4 of those 13 healthcare workers were healthcare workers we had put in quarantine so that we did not have secondary exposures from that, transmission. So lesson 4. The other way, so I told you, remember the first way COVID is going to come in is from symptomatic, unrecognized patients when we admit them. From colleagues, the second way is from colleagues and coworkers that are mildly sick and are working while they're sick. And unfortunately, we've had about a dozen doctors who were tested positive. And unfortunately, except the 2 that we've just put in quarantine, most of them were working while they were sick. In fact, we had a resident who insisted that despite being positive, wanted to come to the OR tomorrow because this was the case of his residency. And we really had to be forceful to prevent him from coming to work. So if you have symptoms, get tested. Stay home until we have the test results. But even if the test is negative, you stay home for at least until your symptoms have resolved for 24 to 48 hours. I told you about the early test that you may be negative. If you still have symptoms, we can repeat the test 48 hours later if you still have symptoms. And if you test positive, we repeat the test at 14 days before you come back to make sure that we have no trace of virus before you come back. We've had about 50 healthcare workers confirmed. And as I told you, many of them unfortunately have worked while they were sick. And this is one of the reasons why we've introduced universal mask in the last week. Well, my dream, if I could do this, I would test everyone every day, including all healthcare workers, while they're in the hospital. I wish we just could test like we do distance temperature on your forehead. And I think that probably would tell us what the real situation is. But unfortunately, that would probably require 1,200 tests a day, only for the Glen. We have 12,000 employees at the NUHC, plus our 750 patients. So imagine the maths. Maybe we'll get there, but we'll need a lot more testing capacity. The second dream, well, really, if we could have N95 masks for each interaction with anyone all the time, that would be fantastic. There's no question that N95 masks are better, whether fit tested or not. They're better masks, but the reality is that in some size, we have only a couple days left of supply. For other size, we have 2 weeks of supply, but just as the lab, our N95 reserve is relatively finite. And I'm gonna stop this. If you can drop at your pharmacy, they might have some Halloween stocks left that may be useful. Thank you. And I guess we'll open it to questions.
Maybe, you know what, Charles and Marcel, maybe I'll just go to some of the questions that might, from the chat, that might be especially interesting to everybody. So one of our anesthesiologists wants to know what you think the sensitivity of the test in Quebec is. 70%, 80%, 90, you said 80 to 90 in symptomatic people. What about in asymptomatic people?
Hi. I don't think we can say there's a gold standard. So all we can do is say there's a bunch of people who are negative and then positive, and those are anecdotes. And then you can come up with some number of 80 to 90. To me, probably the more important thing is at a collective level, if you've got 10 to the 11th virions, we'll find it. If you have 10 to the 3, maybe we will miss it. So by and large, the test is going to find the people who are likely to cause the biggest problems. And we've all worked in the past with acid-fast staining for TB, and the AFB positives are much more contagious than the AFB negatives. So is it 80? Is it 85? Is it 90? I don't think we can know, but it's picking up the most contagious people, and that's what we can do the best.
Can you address, so as Dr. Frenette said, many of our patients having head and neck surgery or lung surgery will have, by definition, almost one of those symptoms on the list. And I'm sure we could do a better job of screening those patients and putting those protocols into place at multiple levels of the patient trajectory. But wouldn't it make sense, since, as you mentioned, the symptoms are so overlapping and the implications of a positive test are so important in that particular population, wouldn't it make sense to just add that testing to, for those patients? Like you said, it's not going to change probably very much in the OR at this point, but it may change what happens to that patient on the floor. So can you address why we wouldn't test the very few patients, let's say 5 a week, that would fit into that category as an extra layer of confidence to add to our clinical screening?
So I'll give a first answer, which is theoretical, and then I'll have Charles give the more practical side. When we did a tuberculosis outbreak study in northern Quebec, some of the people who were found as contacts, who just were brought in for a skin test, were saying, I'm fine. But when you observed them, they were coughing. And some of the contacts were actually sources. So I think we should recognize that the symptom, I am coughing, is not the same as I am coughing. And that a lot of people who just think they have a smoker's cough can't actually distinguish whether they are coughing more than they've been coughing before. So I think we should be vigilant that asking people, do you feel like you're coughing, is probably imperfect as it is. And we should really be thinking harder about, just if the person is audibly coughing, we should also be testing them. That's my first thought. Charles is going to give you the more concrete answer.
So, you're absolutely right, Leanne. I suspect that any thoracic surgery patients has either a cough, a shortness of breath, or respiratory difficulties. So they fit the definition to be tested. I cannot tell you he's been coughing because of his mesothelioma or because of his community-acquired pneumonia. So to me, that's a no-brainer. I'll tell you, the rest division asked me 4 weeks ago. He says to me, listen, all our patients are coughing, all the COPD, should we test all of them? I said, yes. So to me, those are no-brainers. But on the other hand, if you're gonna, have someone who crossed the street on Sherbrooke, was hit by a bike and has a tibial fracture, and, he's had no contacts, no travel, he's been self-isolating, I think that fracture needs to be operated, but to be honest, I don't think he should be tested. I'm giving you two extremes, and obviously in between, there's probably a lot of gray zones. And we've been very liberal of testing. One of the points as well, I want to tell you, that list of symptoms that I've told you is very, very extensive. It's probably the most extensive I've seen of any site. Okay, I'll tell you, I've visited a long-term care home. The only symptom they ask are fever and cough. So they're going to miss people. And I'm not surprised that we have so many cases in long-term care because they don't do a good screening job for all these other symptoms that may be manifestations of COVID.
Okay. There's a lot of really good questions, but I'm going to do the sort of more clinical ones first, and then I'll go back to some of the test characteristic questions. So when we talk about ophthalmology a little bit, I think there's some confusion in the OR with the eye surgery. I know, Charles, you and I have come up with something, but there were still some questions even yesterday. So I guess on some lists, on all the lists, the eye surgery comes on the same list as a high-risk procedure like, oropharynx and airway. Could you address that and how we should best be, protecting people in the OR for those cases?
Yeah, so, it's another one of those gray zones. There are things we know or things we don't know. So what we know is that the eye definitely is a site by which the virus may enter. The epithelium on the eye is the respiratory tract epithelium. It has the receptors for the virus. And there are clear cases of quote unquote conjunctivitis associated with COVID, and clear cases where in fact it was the initial manifestation. Now, what we don't know is what is the risk of one doing an aerosol, creating an aerosol from an ophthalmic procedure. It was never considered an aerosol generating procedure ever, one. And two, what type of precautions might prevent transmission from that surgery? Is it just a regular surgical mask, or do you need an N95 mask? The third thing is, well, if you have it in the eye, there's a high chance that you have it in the respiratory tract. And so that's why one of the guidelines suggested, well, if you're doing local anesthesia, even if the virus is there, you're not going to generate aerosols, small aerosols that are transmitted by the airborne route, versus if you do general anesthesia and you intubate and the virus is in the eye, it's likely to be in the airways, and you're doing an aerosol generating procedure, so then you should wear full PPEs. So that's where the gray zone may be. My personal thought is that under general anesthesia, you should probably, in a COVID suspect case or confirmed case, ophthalmology surgery under general anesthesia should definitely take airborne precautions.
Okay, thank you. So we're just going to try to get through some more of these. So somebody asked if they have one of their trainees is symptomatic, fever and myalgias, has had 2 tests a week apart, they were negative. Can he still have COVID?
Definitely, yes. In fact, I have to tell you, one of the other patients I saw in clinic returned from Italy from a skiing trip. This is end of February, early March. He had all the symptoms. He was coughing. I saw him about a week after the start of disease. His test was negative. I said, come back, I'll redo the test. Second test was still negative. But you know what? After I saw the epi in Italy, I am sure that he was a COVID case.
Okay, so so what is your recommendation for that trainee for when he can come back to work?
So the good thing about thing is that if his test is negative and the test was well done twice, he's probably not very contagious, whatever he had, and that he should stay home until the symptoms have resolved for 24 to 48 hours. Because it may be, you have to remember, it may be influenza. There was still about 5% circulation of influenza in March during this, and we were still seeing other viruses like rhinoviruses, RSV, all through February and early March.
Okay, a couple just questions here from for thoracic. Do pathologists and technicians need to wear N95 mask, PPE when performing frozen sections?
So frozen sections are not on the list of aerosol generating procedures. However, autopsy is. So no N95 for frozen sections. I believe they do this outside of the OR theater. Obviously, if they were in the OR theater and that if the case was under airborne precaution, when they go in, they should they should take airborne precautions in the OR. But to look under this, to the slides under the microscope, they don't need to.
Okay, even if it's a fresh section and they're slicing it up in their little room there, put it under the microscope. Sorry, we'll just make sure everyone's muted. So the question is, when they take the specimen and they slice it up and then they put it under the microscope, they go in a special room to do that. Is that's you consider that to be safe? They don't have to wear precautions for that.
Correct. Okay. The lab management is in an ever-changing guidelines. You know, we started to treat this in the lab initially with full gown, N95 mask, as if it was a TB case. And that's probably correct for people who work on cultures. But more recently in the guidelines by the LSPQ, they've downgraded the recommendation to treat clinical samples as a level 2, which means you work under the hood with the appropriate protections, but you don't need the level 3 precautions for, clinical samples.
And okay, maybe, I don't know if you guys can stay like 5 more minutes because there's a lot of questions. I think they're really good clinical questions, if that's okay.
I'll give you 2 more minutes.
I can stay.
Okay.
Okay, so another question that often comes up. So we know that endoscopy, upper endoscopy is, considered aerosol generating. The same with, transthoracic echo. Obviously, that's endoscopy. And then the question comes up about NG tube insertion.
Yeah. The aerosol generating procedure is sort of another area where there's a lot of unknown. And, we asked the INES to really review the evidence. And they came up with a list of things that were well studied and seem to have an increased risk. And that's the list that we are using at the MUHC. Then there was a second category of things that may be suggestive by different either associations, but there was no scientific evidence. And those procedures are also part of the list. An example is transesophageal, for example, echo is part of the list. GI endoscopy is part of that list. And then there's a third list where there's actually good evidence that there's no aerosol generating procedures. And that list includes, for example, regular nebulizing treatment with Ventolin. So all the others, we don't have. So people who have generated, if something makes you cough, people have interpreted that this is an aerosol generating procedure? Well, routine care, people with cough is contact droplets. So just inducing a cough is not an aerosol generating procedure, and NG tube would fit in that category. But there are a lot of gray zones where we actually do not have much data. I agree completely with the concept that Marcel is saying, that there are probably some people that are have higher viral load or super spreaders. We've attempted to identify those people in two ways: the critically ill patient and those procedures that are usually done for a reason because the patient is really sick. So we call that the critically ill patients and the aerosol generating procedures that are done on those patients. So if you're going to put, NG tube in a patient who is, on high dose oxygen or is in respiratory failure, definitely should do or take airborne precaution. On the other hand, if you're going to put the NG tube in someone who's asymptomatic, you probably don't need the airborne precautions.
Okay, Charles, it's 8:33, so
Thank
you're
you.
off the hook. Thank you very much. Thanks a lot, Charles. We really appreciate it.
Sure.
Marcel, back in the hot seat, cleaning off the mouse. So a couple of questions about the test. So about immune globulin testing or an antibody testing, is that something that's coming up?
Yeah, so thanks. I think Renzo told me he was going to ask that yesterday in the hallway. So it's coming fast and furious in the lay media. There's all kinds of articles on CBC about labs that plan to do 1,000 a day. We don't actually know the sensitivity and specificity. Some of the early studies that have been published on what's called medRxiv, so these are preprints that haven't even been peer reviewed and come out in any journals, are saying that people who have had symptomatic COVID disease that's PCR positive are, 30% of them are not even developing detectable neutralizing antibodies. So the sensitivity doesn't seem to be good. We don't know what the specificity is because we don't know if it's giving a positive for last year's coronavirus. I'm unaware of somebody who's taken out SARS serum from 2003 to see if that gives false positives. So what I see in the next few months is serology may be useful to do population studies to get a sense of how many of us have been infected across a community. I don't think serology is going to be useful at the individual level. And the idea that if you're seropositive, you can go to work, and if you're seronegative, you can't go to work, what are people calling immune passports? I think that's not likely to work because we don't know if the serology is good enough to predict that you are safe or at risk.
Okay, Marcel, can you talk a little bit? I think there's some confusion about positive pressure rooms, negative pressure rooms, SAS antechamber. So specific questions. So if you're in a negative pressure room, okay, yeah, let's start with that. You're in a negative pressure room, you're doing endoscopy, you do a scope. Do you have to wait for any air exchanges before you do your next patient?
I haven't actually read the infection control guidelines. I would have asked Charles that. Clearly, if you are doing aerosol generating procedures, you should be in a negative pressure room. If you are doing something that might make somebody cough, that returns to be taking care of a COVID patient on a ward. And for a COVID patient on a ward, that person could cough, but we don't wait for 6 air exchanges or something to go in and out of the room of somebody who coughs. So I'm going to have to ask you to defer to either Charles or Eva Ryda on everybody's particular procedure, because I can't say that endoscopy is the same as a transesophageal echo, which is the same as head and neck surgery.
Okay, and also, I mean, we get into that a little bit in our OR protocols because obviously an operating room cannot be a negative pressure room, and we use a negative pressure antechamber for very high risk patients or COVID positive patients. And in our regular rooms that are positive pressure rooms, we wait depending on, because this was a question, depending on the site. So at the Montreal General Hospital, we know the ventilation air exchanges are poor. So we've given recommendation for 35 minutes after intubation, after extubation, which, as we all know, and it's about 20 minutes at the RVH. So it may depend on your situation, but it's something important to check in, and that should be part of your protocols in endoscopy suites or wherever you're doing echoes and things like that.
Agreed.
I think, so that's questions about that. For the endoscopy questions, I think again, well, so here's about where patients should be recovering after endoscopy. You know, if they're scoped in a regular endoscopy room or a negative pressure room, do they recover in that room, or can they place a surgical mask on the patient and they go to the PACU? So I would think these are kind of protocols that really should be there in place.
Yeah.
But I don't know if you have an answer to that.
I don't actually. I hope there are protocols, but I encourage every division to do what Leanne has done, or department, which is if there's not a protocol, write it and then ask somebody to correct it. But if you feel like you have a patient situation or patient trajectory that for which there's not a protocol, please speak with Eva or Charles and develop a protocol so that we don't have 20 people sending 20 emails about the exact same situation. And then, of course, that risks getting various different answers, and that only leads to confusion.
Okay, so I think that's pretty much most of the questions. Michelle Picard, who's the associate DPS for endoscopy, says there is a protocol, I think. So something to, maybe Michelle will follow up with all the endoscopists to make sure that everybody's aware of it. One final question is about wearing masks. If I guess I would interpret the question as if healthcare workers are wearing masks, shouldn't all patients coming into the hospital wearing masks? Everyone who steps into the hospital wear a mask.
Yeah, and I think we can all watch Sanjay Gupta on CNN, and I can't say that there is a single answer to it, nor that the answer today is going to be the same as the answer next Tuesday. What I like to do is to paraphrase JFK and to ask, what can I do? Ask not what can I do to avoid getting infected, but what can I do to avoid transmitting infection? And hopefully we can all try to think of what is it we can do to prevent ourselves being unwittingly the propagator of viral transmission. So then the idea is, if I have a cough and the sniffles, I should wear a mask at work? No, I think I should just not come to work. And that's one of the things we should all be asking, and hopefully the patients see it the same way. If we all wear masks, maybe it'll work, but there's always the risk that we fiddle with our masks. And I see people walking around the hospital with masks on their chins because they're eating and stuff like that. So it's not perfect to wear masks if you recognize that people are going to be moving the masks around on their faces all the time.
Okay, Marcel, really, thank you very much for taking the time to do this. I think we've got through most of the questions. If we didn't, Dr. Behr has already generously offered that he will take your emails, and really appreciate it. I know you did turn this around on very short notice. I think there's really a lot of good information in there. And so we appreciate it very much, Marcel. Thank you, and have a good day.
Thank you, everybody. And I'll make the 2 talks as PDFs, and I'll send them to Sonia so that they can be put on your departmental whatever site, okay?
Yep, great. Thank you. Bye.
Bye-bye.